Thank you very much. It's a pleasure to be here and speak with the family physicians. I'll shrink my bio a little bit and tell you that it's one anticoagulation clinic, and I collaborate with a lot of different agencies through Lower Mainland and work with the hematologists at VGH as well as RCH. So we have one clinic, and at that clinic in Surrey, we have a catchment of 2 million people. We do treatments for DVT and pulmonary emboli and any other clots that are initiated for treatment at Surrey Memorial Hospital. So we are very busy. We are a 7-day-a-week clinic. We have a staff of six pharmacists, and we do fantastic work with our family physicians. So we set up our patients on anticoagulation regimens, send them back to our primary care physicians in Surrey. So with that as an introduction, I'll go into my presentation. As a clinical pharmacist, I worked in Fraser Health Authority, and the only grants that I've had are through Vancouver Foundation and CAIHAR. No honorarias, no consulting fees. I'm paid by Fraser Health and currently working as an outpatient clinician. No financial support, no in-kind support at all, and my disclosures are that I'm very evidence-based. I always have been. To some extent, I could be a purist with some of the views that I may have, which my colleagues balance me out very well with the real-life stories of the patients. So that's the only declaration I have. We have a lot to cover in the next 20-25 minutes, so do excuse me if you find that I'm rambling through the slides, but the slides are there for you in the package. There's a lot of information for you to fall back on, and at any time you can email me if you have any questions. Very quickly, we'll go through the pharmacology and just show you some of the highlights I think that are important for us as clinicians. Give you some summary on literature and AFib and VTE. Talk a little bit about guidelines in surgical bridging and how to switch back and forth between the new agents and warfarin. And I have 2 case studies just so that we can go through in our minds as to what are some of the considerations for the patients when you're prescribing oral anticoagulants. So at this time, we have 3 new oral anticoagulants available in Canadian market. All of them are available for hip and knee, AFib. And what we have upcoming is also for DVT, for apixaban, probably the Amplify study is going to be coming out soon. So even though dabigatran is not approved for DVT and pulmonary emboli, there are studies, and to some extent, some clinicians would consider that particular agent for that indication. I have given you approximate cost. It's about $100 a month for the patients, and as you know, warfarin is quite cheap. We all know the mechanism of action of warfarin, which affects 4 different vitamin K-dependent cofactors. And we know that anti-10A inhibitors work pretty close to the end of the pathway, and then the thrombin inhibitors right at the bottom of the pathway. And this is something that's important to understand when you're thinking about bleeding, is to when you have agents that are so far down the pathway, it becomes harder and harder to reverse the bleeding. So the pharmacology, and I think for the last 10, 20 years, we've been searching for drugs to replace warfarin for all the problems that it has. And we know that it takes a long time to get it working. Half-life is very long and different in different people. We know that there are a multitude of drug interactions. We know that it requires monitoring. All of these are issues that are considered to be problematic in daily practice. I do want to point out to you that when you're looking at new agents, that you do need to keep a few things in mind. Half-life of the new agents is quite short, which means that if their compliance is not so good, that they are at risk. Adherence is a problem with every class of drug that you use, including warfarin. The only advantage with warfarin is that somebody is on to you, somebody is hounding you, somebody is asking you to go for blood tests. Whereas this agent, there isn't anything like that. So adherence Technically, if you apply the statistics in the first year, 30% to 50% can drop off or be erratic at the use of these agents. Renal function is important consideration for dabigatran, especially if you're going to be looking at dosage modification. But renal function is an important consideration for all the agents because you're looking at high bleeding rates once the renal function goes down. When I'm counseling my patients about the new agents and I'm telling them which drug interactions they need to be careful about, or I find that I'm using the same language with the oral agents about the new oral agents about drug interactions as I am about warfarin. And I'll show you why in the next few slides. The antidote is an important consideration, and this is something as physicians, as clinicians, we need to let our patients know that we're choosing a drug for you, or we think you should be on this drug if you're going to be choosing the drug for them, and that it doesn't have an antidote. How do you feel about that? And I think a lot of people need to be making decisions based on some of the facts that you can give them. Drug interactions. What do you need to know about drug interactions? There are two kinds of drug interactions. There is one called PGP inhibition or induction. PGP is a carrier that is found in many different parts of the body, blood-brain barrier, as well as hepatic system, as well as the gut. Many systems have PGP carrier, and you will find that a lot of drug resistance when it comes to chemotherapy, when it comes to antibiotic therapy, is related to some of the mechanisms related to this particular substrate. A lot of new drugs are screened against PGP because you need to know the interaction. So these new agents interact with PGP, and such that the interacting substrates and combination of new oral agents and these new and the drugs listed here means that you need to avoid. You need to avoid the antifungals. You need to avoid some of the antiplatelet agents. You need to avoid some of the anti-rejection drugs. You need to avoid some of the antibiotics. You need to avoid phenytoin and seizure drugs. So the language becomes very similar as you're counseling the patients about warfarin versus the oral agents. So what's the best thing you can do? Talk to a pharmacist. That's what you say to anybody that is on warfarin as well. So don't forget, if you're prescribing these new agents, you still have a list of drugs that you need to avoid because of drug interactions that I have indicated here. The drug interactions are not simple. Some of these increase the drug levels by 30%, 40%, or 60%. So you need to be aware that the drugs need to be discontinued. Let's go through one case study just to exemplify what kind of literature you will be looking at and to make your decision. So here's a case of AFib, 75 years old male. He has hypertension. His creatinine clearance is 58. He is on a few medications. He's a non-smoker. He drinks alcohol over the weekend. He presents in the emergency department with symptoms and is diagnosed with TIA. CHAD score 2 is 2, and his risk of stroke is 4. Has bled is 3, and his risk of bleeding is 3.74. Anticoagulation, according to the guidelines, is recommended. And when you look at the guidelines, all the recent guidelines indicate that yes, for anybody with CHAD score 2, of 2 needs to be on anticoagulation. So this is our patient. So we are now choosing a drug. And these guidelines indicate that you should be choosing the new oral agents. So here's a summary of AFib clinical trials, and I've picked just the new oral agent trials. And there are 4 of them, and I just want to highlight a few things about them. What you see is superiority of apixaban versus warfarin in Aristotle trial. Secondly, in the RELY trial, you see superiority of dabigatran 150 milligrams versus warfarin. What you need to be aware of is study design and also the comparators. And in my mind, as an anticoagulation pharmacist, the time in therapeutic range, the mean TTR, for warfarin is rather poor. 62%, 60, 64%, and 55%. In my mind, this is poor. Now, in your mind as a clinical practitioner, and you have patients in your clinic, you have to think about what is time in therapeutic range for my patients. And this basically means what percentage of time are you able to keep your patients between 2 and 3 INR. And there are programs you can download from internet, and I use one of those. It's a downloaded program. I just enter the date and the INR. It gives me what the time in therapeutic range is for my patients. So you can do that very easily. In my mind, these large studies with 18,000 patients have very poor time in therapeutic range. So these are very poor comparators. So if you have a non-inferiority or superiority for a poor comparator, to me, I'm still not impressed. The other thing is that the open label trial, it doesn't impress me either because there's a lot of bias that goes into that. So I have some doubts. One more thing is in the rivaroxaban trial, just bear in mind that they enrolled patients that were CHAD2 score 2 and more, not less. Beyond the randomized trial, the better evidence comes from when you combine the strength of the trials together and put the results together to see what they say. And recently in March, CADETH had done this, and they have released the results. And very briefly, they say that apixaban, bigatran, significantly reduced the primary outcome against warfarin. However, the absolute differences in the outcome were between 1 and 6 outcomes per 1,000 patients. So clinically, is this beneficial? Is this relevant to your clinical practice? How important are these outcomes when you put them in numbers like that? And these are the plots that they gave you. So if you're familiar with forest plots, they have paired-wise comparisons of new oral anticoagulation versus warfarin. So the straight line, vertical line is a line of unity, warfarin. And if you're on the left-hand side, it favors treatment. If you're on the left-hand side, favors warfarin. You will find the two green spots, the apixaban and dabigatran, are just marginally on the other side towards favoring the new treatment, and they state superiority based on the non-inferiority study. And if you look to the very right-hand side, you will see that the numbers that they are reducing per 1,000 per year are between 1 and 10. So how significant are these numbers to you if you're going to be choosing the new oral agents as primary, the first line choices? Bleeding is a concern. Bleeding is a concern for any oral anticoagulant you use. And when you compare that with warfarin, again, you see some disappointment. We are looking for an agent that is much better than what we're seeing here. So the major bleeding rates are not that thrilling either when you put it in this perspective of the forest plot. Time in therapeutic range. This is a publication from Lancet, and this is a graph that shows Kaplan-Meier curves. The main points in this study are that dabigatran is not superior if the time in therapeutic range is higher than 65 or 66. So if you're able to maintain your patient with warfarin INR 2 to 3 80% of the time, or 90% of the time, or 70% of the time, dabigatran is not superior like it had been shown in the RELY study. If you have good INR control associated with lower, it is associated with lower risk of bleeding. So there again, there is some evidence to show that if you have better control, then you don't have to worry about bleeding risks are not as high. So if your time in therapeutic range is high, your mortality is also improved with warfarin. And local standard of care affects the risk-benefit ratio. So this is important for us to bear in mind, and particularly in your case, you want to think about your practice and your patients on warfarin. This is a rather complicated diagram, and you can read this on your own time, but basically what it says is that, if I can get the pointer, Basically, what it says is that when you look at the bleeding and the primary outcome of stroke and systolic embolization, you're really not too far away from warfarin in terms of its benefits. So the systematic analysis indicated that the centers with poor control, i.e. INR less than 66% time in therapeutic range, dabigatran was good for them. The duration of these studies is 2 to 3 years, so going forwards, we don't know the effects of these drugs in the long term. Real-world safety data is still to come. We still need to gather some more information. And a caution that even though the studies didn't enroll patients at creatinine clearance 25 or less, 30 or less, they used the agents in people with creatinine clearance 50. I would caution you that these are the people that decompensate very quickly, and you do need to monitor them. And you could be going on using drugs in these patients with unrecognized risk of accumulation and bleeding. This is probably a diagram you've seen before many, many times. This is from RELY study and indicating time in therapeutic range for various countries. There are some countries here looking at this data didn't adopt some of the new drugs and have them on their formulary. We are at, in Canadian centers, the time in therapeutic range was about 71 to 72%. So what was the recommendation by CADTH? CADTH says that you should use anticoagulation as per the data, CHAD score 1 and more, and only use the new oral agents if you cannot manage well with warfarin. Okay, so in this particular case, what are the things that you would be concerned about? Age, that's one. A lot of these studies had enrolled patients, average age 70 years. There were 20 to 30% in some of the studies. The patients were 75 and over, but not that many. I would be concerned about creatinine clearance, and I would be monitoring the patient's creatinine clearance. There are drug interactions that are not known. We are keeping an eye on all the PPIs and SSRIs with the new oral agents because they do interact. We don't know right now the effect of the interaction. Compliance pack, you cannot put dabigatran in the compliance pack, and if somebody has, as I mentioned before, adherence issues, then these are the drugs that are even more dangerous to give to somebody who's not going to be adhering to them. So adherence counseling is very important. And again, a very high risk of major bleed. So is it better to put them on a new oral agent, or is it better to put them on warfarin and monitor them? And of course, you want to think about whether you want to use ASA if you're going to be changing them to an oral anticoagulant. So those are the considerations, and you have the choice of whichever one you want to choose. And of course, I would try warfarin first. I definitely would. That's what I do. Next case, pulmonary emboli and DVT. Here's another 40-year-old gentleman, very tall and very muscular, 115 kilograms. I had a very difficult time giving him shots. I'm going to run through this case really quickly. And so here we are. He looks, he needs to be on an anticoagulant. Studies here, once again, indicate that time in therapeutic range is not so impressive. They're open-label trials, and all of them show that they are non-inferior. None of these trials are superior. So oral anticoagulants are good agents, but in my mind, are they really the first-line agents? We do have data on secondary treatment. That means that if they have, patients have been on warfarin with enoxaparin for the first 6 months or 3 months, can we change them over? This data shows you that, yes, you can change them over. Again, time in therapeutic range, either not reported or very low, and open-label trial. So in our case, one of the concerns that I would have is that not too many patients were tested for over 100 kilogram weight. So it's the higher you go on the weight, the lower the the lower the exposure rate to the drug. Your serum levels are going to be much lower, and like I said, you're comparing at 66% equivalency or non-inferiority of warfarin. So in somebody who is a bigger weight, you may be compromising as to how much anticoagulation you're giving them. And the other thing is that this is a person that is recurrent DVTs. So you really need to be monitoring them well, and we don't have data on 2 to 3 or 4 recurrent weights, DVTs. So some of the important considerations for the new agents, for some of the indications, the patient has to be willing to pay, patient has to understand the risks if they are missing the medications or they are non-adherent. They need to be comfortable with the fact that you don't have an antidote for them. And also, if you have GI symptoms, then dabigatran is really not a good drug because it comes with 10% GI symptoms. And if you have anybody that has a risk of MI, then dabigatran is something that we would not be preferring as well. Apixaban comes with lower risk of bleed of all the oral agents. So those are the considerations for you if you're going to be using the new agents. For warfarin, if you're going to be using it, you want to try and target time in therapeutic range over 66 so that you are superior than the newer agents. You can use it in renal dysfunction. You can use this agent in liver dysfunction. If you have extremes of weight, you can use it in those patients. If you have adherence issues, in my mind, warfarin is a better agent to use. You can at least test, and you have them closely monitored, so you are hounding on them. Indications that are not approved for the new agents are mechanical valves and valvular AFib. Anybody with substance abuse and thrombophilias, the very strong thrombophilias, were not included in the new agents clinical trials. Now, what I have for you, and I don't have the time to go through, but I purposely included this in your package, are risks of recurrence of VTE. So how do you decide how long to continue oral anticoagulants for? So this particular slide gives you that information. So please do go through it. And I do have a reference that does very good overall discussion about that point. So the next 3 slides are on balancing risk versus benefits. So if there are some patients who are at risk of bleeding, you need to think about, do I give them something anticoagulant or not? And you may have to stop and go for a while. I have also included information about perioperative management, to be careful with the oral anticoagulants because we do not have a test. A lot of the surgeons and hematologists are scared using these agents, even though it's easier to stop and start these agents. But if there is a bleed within the surgical perioperative period, these bleeds can be quite difficult to control. You do not have a test to see if it is safe to proceed or stop. So there's lots of guidelines, and I've given you the handout in the website for that. How to switch from warfarin to the new agents is very easy when you're at warfarin INR 2.2 or 2.5. Just stop the warfarin that day, start your new oral agent. Switching from the new agent to warfarin, and that has happened. Again, I've got guidelines for you as to how to do that. So you would be using the new agents as a bridging therapy. Keep in mind that apixaban, rivaroxaban do affect INR testing. So for about 2 or 3 days, your INRs will not be accurate once you stop the new agents. And then by day 3, day 4, the INRs will be accurate. Okay. And then the parenteral agents as to when to start and when to stop with that. Bear in mind some of the counseling points on dabigatran, very important information you need to relay to your patients. Store the tablets in the original bottle. Do not carry them around like you do in travel packs because there is a desiccant in the cap of the bottle that keeps the humidity of dabigatran stable. Otherwise, it is affected. You cannot repackage the capsules. You cannot open the capsules. If you open the capsules and put it on food, then its bioavailability becomes higher, so you're getting a bigger dose. and do not crush. Okay, so that is very brief, very fast, quick review. Any questions?